Hey, this is Gary Kopachinski for eNews Park Forest, speaking with Dr. Timothy Angelotti, Associate Professor of Anesthesiology, Perioperative and Pain Medicine at Stanford University Medical Center. Full disclosure, we went to college together at Notre Dame, graduated 1985, and so here we are seeing each other face to face for the first time in 35 years. Both of us lost a little bit upstairs.
Yeah. You could see that from my whole family tree. There was no losing that. I'd love to say my twin brothers lost more hair than me, so it's okay.
There you go. We're at the mercy of a virus that we're learning a little bit more about every day, and we still don't know a lot about. I asked you for your time if you would talk about why masks help. That seems to be something that people come back to. There are people playing nose commando. What are the benefits?
Okay. Well, I'll start by saying this. My background's in critical care medicine as well as anesthesia, but obviously this has impacted us. So I'm not speaking as a person who's, quote, an expert in masks, but I can tell you what I do know and what I've read. The first thing is simply this: everybody has to understand, if people are going to look for data, meaning I'm a scientist, I have a PhD as well, so I always look for data. And if people want to look for data for masks, it's not as good as you would like to think it is, because quite honestly, we've never had to worry this much about wearing masks as a public health measure probably since 1918 with the previous Spanish flu. And that was the last time this happened. And as a note of history, because I'm getting more into history as I've gotten older, the exact same problems happened in 1918 with respect to wearing masks by the public. It was considered to be an individual mandate. It was looked at as an individual choice, and kind of the same arguments that we're hearing then, we're hearing now. So in general, I wish I could bring up a graphic. I have to find it. Someone posted on Facebook, but simply like this. This is a disease that we know nothing about when it first came out. We don't have any natural immunity. However, there's some question now about some recent findings I could be glad to discuss. But in general, when the first mask mandates came out in March, it was because we had nothing else to offer. There were no drugs. We didn't even know how this disease presented. There's obviously a lot of differences in it. So masks became the easiest way to control spread, as well as, very draconian measures like lockdowns, or even to the point what they did in China, which is basically martial law almost in Wuhan. So the thing about masks is simply this. They're not tight fitting. We're not talking about N95s. We're not talking about those types of masks. We're talking about your simple, basically a surgical mask. And the idea is this: if you're wearing it and you're infected but not known, you're not going to spray it out in the world. Now, everybody likes to come back and say, well, it doesn't protect you, because obviously the mask isn't an N95, which is more for protecting you, because that's a tight seal. It doesn't allow anything in except through the mask, hence it's a filter. A surgical mask is simply this: it's to prevent other people from being infected by you. If you're unknowingly infected, it will prevent you from being somewhat infected, though the question about the effectiveness is, if you're wearing a mask and someone isn't and they're coughing on you, I think I saw the order of like a 30% chance of getting infected. Now, the problem is there is no data, so I don't know why people say it's a 30% chance or a 5% chance. But basically, distance and wearing a mask prevents you from breathing each other's expelled, aerosolized breath, which in some people it could be infected and contain COVID. And that's really the long and short of it. It's to just prevent the spread out in the community.
I appreciate that. I think the only way to convince people who still are hesitant or hold it as their political right to not wear a mask is to just keep pushing out the facts.
Yeah, I totally agree. Here's the thing. I used to say to people, you know, you wear a seatbelt, it's publicly mandated, and you don't fight on that. But someone else said that's not really a good example, because if you don't wear a seatbelt, you're more likely to get hurt, and therefore it is an individual choice, he would say, because you're not hurting anybody else. The better choice would be you don't maintain your car, and if you live in a state where you have to have inspections, imagine in a state where you didn't. So yeah, I've got faulty brakes, but I know how to work them. That's a better example, because if you don't fix your brakes, you could hurt somebody else. And states that require to have, not all states do, obviously, and some states require inspections to make sure your car is safe. That's why. You don't fight that. People don't say, you know, it's my car, it's safe, I know what I'm doing, I'm a better driver, don't worry about it. No. You have to do it. The government mandates it, and everybody agrees. And in fact, everybody pays for the service, which makes it even better. A simple mask will prevent spread. It's been shown. Every country that's done it in an aggressive way has demonstrated control of the spread. The problem we have in this country is, and I'll go off topic and be political, it's the idea of American exceptionalism. We believe that we can fix this problem because we always have fixed the world's problems, so we'll fix it. And then when you get false news about cures, hydroxychloroquine, chloroquine, and all these other types of things, and even worse, quack cures, then people have a false sense of security. So the idea is, well, you know, if I get sick, so what? Most people don't get that ill. The key thing everybody has to remember, and I get sick and tired of this, more people die from the flu or something else along those lines. The problem is, it's not about death. It's not about the healthy people or the people that get very little illness from this. It's about the surge that can happen in a hospital setting when you have a whole bunch of people get infected, because we do know one data that point that's pretty solid is between 2 to 5% of infected people will be hospitalized. So if you have 100,000 people, that's 5,000 people showing up. If you've got 10,000 people, you do the math. So that's the real thing. And what really bothers me is that the media has been harping on test positivity and death. And what they haven't talked about is hospital utilization, because that's what I experience. Luckily, we have a very solid, plan in place at Stanford as well as Northern California. So we're not getting hit as bad as LA is, but that's our biggest fear. And that's what people don't appreciate, that, if you want a hospital full of people who are full of COVID, then keep doing what we're doing. And then all other medical care will go by the wayside until we get control of this. You want us to cancel elective surgeries again? You want us, people are afraid to come to the hospital, so they're not getting the care they need, and more people are dying at home from MIs and heart attacks, whatever. That's why you need to wear a mask. It protects everybody, and it keeps the system in place going and doesn't allow us to get crushed.
And I don't think I said this since I started recording, but for anybody who's watching, thank you. The background chatterbox is a parrot, and
okay.
I'll go into this later, but I had to do the interview from home. And Tim, are we closing in? Does there appear, what do the chances of an antivirus look like?
Well, here's the thing. I basically, in March, when this thing first came out, I started hearing the reports about hydroxychloroquine and other things. And, of course, being at a place like Stanford, we're a cutting edge science. So I'm hearing all kinds of stuff. And I made some predictions. And so far, almost every prediction I've made has come true. I predicted that hydroxychloroquine would fail because I looked at the mechanism of action. My PhD is in pharmacology, which is the study of the mechanism of drugs. So I do this from a basic science point of view. I teach it for so many years, ran a research lab, funded NIH research lab, etc. So I looked into hydroxychloroquine. And based on what it works in for malaria and everything else, I said, you know what? It may have a role. I mean, it may work, but it's a weak mechanism. It's an indirect mechanism as an antiviral. So most likely it's not going to work for very sick people. People who are really infected, it's going to be overwhelmed, and this type of antiviral drug won't work. I predicted at that time that it may work as a prophylactic, but I believe that was the only thing, like they use for malaria prophylaxis. I was wrong on that estimate. That was the only one I've been wrong on so far. I predicted that within a month, in April, we'd start having second generation tests, that by April, May, we'd have antibody tests. I predicted third generation testing, and there's a third generation test that's going to be coming out that's a totally different technology than PCR. So a lot of the problems with PCR go away, and it's much quicker. It could turn it into a few minutes. It's like a dipstick kind of testing that you would get versus this PCR, which takes a while, takes days to get back. So that would be a revolution. I also said the convalescent plasmid, obviously we were using convalescent plasma already, but I knew the technology for converting convalescent plasma into a monoclonal antibody therapy was there. And I've posted some articles about this. The technology is much further advanced than I even dreamed of. And they've already figured out taking antibodies from patients who've had the disease, reverse engineered it into, like, if you heard of Humira and all those types of drugs, those are monoclonal antibodies that are produced commercially. They will be producing convalescent plasma equivalent monoclonal antibodies in the next 2 months. They've already gone in production a month ago. This actually comes out of the Department of Defense, if you can believe it. There's a huge grant program. They set this up for us without realizing it 10 years ago. They were basically charged, the government said, we want to be able to take, if an infectious agent gets used as biowarfare, we want to be able to take that convalescent plasma from an infected soldier and convert it into a monoclonal antibody in 60 days. That was the grant. And there's a company that successfully completed it up in Vancouver, British Columbia. And that technology is the reason why we've taken this plasma and converted it into a monoclonal antibody. And it didn't take 60 days. It took about 4 months. But I can tell you 20 years ago, that would have been an impossibility. That would have taken 10 years. 10 years ago, it would have taken us probably 3 years. Now we can do it in 4 months. The scientific ability around the world, not just the US, is amazing at what they've done, what they've uncovered, and all the things we have learned. The problem is it's so nuanced that the average person can't understand it. And when the media picks up on it and hints at it because they want to report good news or whatever, it gives away too much information that's not readily digestible. And that's one of the concerns. But this antibody therapy will be coming out. They're doing other types of drug therapy. They're using interferons and interleukin therapies now. There's a lot of really interesting stuff. And I told people from the very get-go in March, you got to give us 6 months, meaning the healthcare people. You got to give us 6 months. You got to keep this from getting out of control, because in 6 months, which is September, we're going to have a lot more weapons in our arsenal. And that's what's happening. So those predictions I made, I'm not saying I was clairvoyant, but I was just reading what I knew from the literature and what my scientific background and clinical background was. And that's what we've done. So those therapies are all going to be there. I think an antiviral as a drug therapy, those have been the most difficult. We don't have one for the cold. We have one called Tamiflu for flu, but you have to take it within 3 days. I think other biologics, as they're called, antibody therapies, et cetera, are going to be the way we're going to go. That's what's going to happen. And the vaccine, again, they've gone faster than they ever have with the vaccine. And I believe that around 2021, by the, February, March or whatever, is when we're going to start seeing some vaccine trials and the question about who gets it first, et cetera. That's when that's going to happen. The Russian situation, everybody's talking about it, but all they did is they skipped doing phase 3 studies. They went from phase 2, put it in humans, saw an antibody response, minimal safety, and they're going to throw it out there. Now, they may be ahead of us if it's successful, but if there's any badness to it, it's going to set everything back. And that's the bigger fear. But overall, I believe we're going to have treatments for the disease. We're going to have antiviral therapies for the disease. And I think this is, like I said, faster than ever it's done before. It's amazing the speed at which they've done this.
The Great Influenza was extremely politicized as well. And this has been no exception in that regard. Are you concerned about politicization as who gets protection first?
I definitely am afraid about that. I'm afraid about, on a global level, it's definitely going to be different countries are going to do different things. For example, the largest vaccine manufacturer in the world is in India. And I forgot the name of the company, but they've already negotiated with one of the candidate vaccines from England because they have their own vaccine program going. And they've admitted that they're jumping the gun in production. However, they said if we wait until we finally have all the data to start production, because it's going to be very hard to produce large amounts, we're going to be behind. So they've taken the risk of investing like hundreds of millions of dollars to start producing a vaccine for the English group that they believe will be the one that's going to work. And if they're wrong, it's going to be a waste. But if they're right, they'll jump everybody ahead. But here's what they said: we'll do it, but half the doses stay in India. So that's what they said. For taking this risk, this is what we want. And I can't blame them for it, but that's what's happening. So the who's going to get it will be politicized. And my concern is the approval will be politicized, and they're going to try to push out a vaccine because Trump wants one fast because it'll help his reelection, and he'll push out a vaccine before it's vetted. Remember, some of the early vaccines that were created for SARS, and it's unfortunate, a lot of vaccines for SARS were sitting on shelves and never went to much testing, but some of them actually activate the virus when you get infected. They make the virus a little easier to get inside the cells and get, do their job, their badness. That's the fear. Now, you can test for that and you can weed those out. Has Russia weeded that out? We don't know. So that's the reason why it's going to take a while. And if they politicize the approval process just to get one out, you're going to put people at risk. And if it does go wrong, then what's going to happen is it's going to scare everybody else from ever taking a vaccine of this type or anyone in the future. The technology behind the vaccine doesn't scare me. In fact, the technology for the vaccine, I call it a simple parlor trick. We've been doing it in cell culture and research labs since around 1990. So it's not unheard of to take these RNA vaccines and inject them. The problem is we've never taken an RNA vaccine to market because RNA vaccines tend to have a very short half-life. They're just an unstable compound. So the politics are going to be people trying to push timelines beyond what scientifically can be done. That's my biggest fear.
Gotcha. And I thank you. Thank you for your time and your expertise. Do you have any closing thoughts or?
I mean, first, good to see you. Definitely, if we ever get reunions again, we have to line up and go for it. My own biggest thing is I remember my mom. My mom's 91 years old. Okay, and she's still kicking. She grew up on a farm in the Depression. She was born in 29. She grew up during World War II, and she used to tell us all the time growing up the kinds of things they had to do. This was ration: leather, gas, sugar, flour. Everything they had to do for the war effort, and they did it. And much more than we ever had to do right now. And she used to say to us back 20, 30 years ago, she used to half joke, but she was half serious. If you guys, your generation had to go through what we had to go through, you wouldn't make it. And right now, I kind of look at it and go, this is our moment. And we're definitely proving her right. Because people aren't demonstrating the strength, the conviction, and the stoicism to do what we need to do. They had to put up with something with a very unknown potential future, what they were dealing with. But I guess for some reason, we don't believe that what we're facing is an unknown enough to scare us. And then they throw the whole idea of fear. Everybody just needs to understand, the longer we perpetuate this, and look at all the rest of the world and how better they're doing, the longer we perpetuate this, the more likely this is going to get a foothold, and it's never going to leave the country. It's going to become a bigger year-to-year thing because more people and more situations are going to rise up where it's going to hold on to. The virus is going to live. So we're doing a bad job. And the only way to correct it would be to do a quick lockdown again, but that's going to have no stomach for that. And we've wasted the previous lockdown. We did a lockdown and people put up with it, but we wasted and squandered that opportunity because we didn't follow it up with masks and everything else. We quickly reopened thinking that was all it was going to take because this is how it works in America. So I believe we're going to get ahead of it. I believe we're going to get control of it. I really do, because everything I'm seeing from a clinical research point of view, I just fear how long it's going to take for this country to get back to normal so we can travel internationally, we can do business, we can open up, because we've squandered our opportunity.
Dr. Angelotti, thank you so much. Appreciate your time.
Glad to help out. All right. Take care, and we'll